Welcome to Medic Empire, making medical knowledge easy, one topic at a time. In today's lesson, we're breaking down bronchiolitis in children, a condition you will encounter very often in pediatrics. Whether you're a brand new medical student or revising for clinical exams, this video will give you a clear understanding of what bronchiolitis really is, why it happens, and how it's managed. 1. What exactly is bronchiolitis? Bronchiolitis is a lower respiratory tract infection that mostly affects infants and toddlers, especially those under 2 years. It is predominantly viral, with the number one culprit being respiratory syncytial virus, also known as RSV. Other viruses like rhinovirus, adenovirus parainfluenza, and influenza can also cause it. In simple terms, bronchiolitis is inflammation of the tiny airways called bronchioles. These airways become swollen, filled with mucus, and sometimes get partially blocked. As a result, the child struggles to move air in and out, causing wheezing, cough, and difficulty breathing. 2. Who gets it, and why? Epidemiology. Bronchiolitis is extremely common in babies below 1 year, and occurs 1.5 to 2 times more often in boys. Risk factors include not being breastfed, crowded living conditions or daycare exposure, maternal smoking during pregnancy, older siblings with respiratory infections, prematurity and low birth weight, pre-existing lung or heart diseases. It also has a seasonal pattern, winter and spring in temperate regions, and rainy season or Harmattan in many African countries. 3. How does it happen? Pathophysiology. Let's break it down simply. The infection usually begins when a child inhales virus-containing droplets or touches contaminated surfaces, and then their eyes or nose. The virus first multiplies in the upper airway, then spreads deeper into the bronchioles. Infants are especially vulnerable because their bronchioles are extremely tiny. Remember the physics. Airway resistance is proportional to 1 divided by the radius to the power of 4. So even a small narrowing causes a dramatic increase in resistance, making breathing much harder for a baby. The virus triggers inflammation, epithelial cell damage, mucus hypersecretion, and formation of mucus plugs. These block airflow, leading to wheezing, hyperinflation, and sometimes areas of atelectasis. Their immune system also reacts strongly, releasing cytokines, lymphokines, and IgA antibodies, which further worsen the inflammation. 4. Clinical features: what you see in the child. Most children first show signs of a mild upper respiratory infection, sneezing, clear runny nose, mild fever. Then after a few days, symptoms worsen. Persistent cough, poor feeding, irritability, fast breathing or difficulty breathing, wheezing, low oxygen saturation, apnea in very young infants. On examination, you may hear wheezes, crackles, a prolonged expiratory phase, or sometimes very quiet breath sounds due to poor air entry. 5. Diagnosis, mostly clinical. Diagnosis is based on history and physical exam. Chest X-rays and laboratory tests are not routinely needed because they rarely change management and are often normal. X-rays may show hyperinflation or atelectasis, but again, they are not required for typical cases. If a child has repeated or unusually severe episodes, then you might evaluate for underlying issues like cystic fibrosis or immunodeficiency. 6. Treatment support. Bronchiolitis is mostly managed with supportive care. Oxygen therapy if saturation is below 90%. Hydration, either orally or with IV isotonic fluids. Gentle nasal suctioning for comfort. Importantly, research shows that bronchodilators, corticosteroids, hypertonic saline, and ribavirin do not consistently improve outcomes, so they are not routinely recommended. There is no cure-all medication. The key is keeping the child comfortable while the virus runs its course. 7. Prognosis, good in most cases. Most children recover within 7 hours with proper supportive care. The mortality rate is less than 1% in developing countries. However, prognosis may be worse in babies with severe dehydration, congenital heart disease, chronic lung disease, or immunodeficiency. Interestingly, most infants who wheeze with bronchiolitis do not go on to develop asthma. 8. Prevention. Prevention focuses on meticulous hand hygiene, avoiding overcrowded environments, protecting babies from smoke exposure, using nirsevimab, an antibody used to prevent RSV infection in high-risk infants. Conclusion. And that brings us to the end of today's lesson. Bronchiolitis may be common, but understanding the physiology behind it helps you appreciate why supportive care is the mainstay of treatment. If you learned something new today, don't forget to like, comment, and subscribe to Medic Empire, making medical knowledge easy.